This podcast is for healthcare professionals only and is supported by an independent educational grant from Bayer.
Welcome back to another episode of Oncology Brothers podcast. I'm Rohit Gosain, alongside with my brother and co-host Rahul Gosain. We are on this journey of four-part series of Hepatocellular Carcinoma HCC. Today, we will be focusing, out of the two discussions, the first discussion on intermediate hepatocellular carcinoma. In last two discussions, we have focused on advanced HCC, where we covered first-line treatment options with Dr. Rachna Shroff and the second-line treatment options with Dr. Ramasa and Dr. Vogel.
Today, particularly, our focus is on intermediate HCC with an emphasis on multimodality treatment strategies in this space. We're excited to have two experts with us, Dr. Maria Reig, a hepatologist who's leading efforts for BCLC from Barcelona, and Dr. Emil Cohen, interventional radiology with MedStar Georgetown. Maria and Emil, welcome.
Hello.
Thanks for having us.
Let's kick this off. So, intermediate hepatocellular carcinoma is tricky. Multidisciplinary, rather, is the key here. Maria, we'll start off with you first, given the background and leading efforts with Barcelona Clinical Liver Cancer Staging System, which is the BCLC. If you don't mind briefly touching on what BCLC staging system is, and how do you exactly go about intermediate stage here?
Intermediate HCC is the best example of the need of multidisciplinary team because we have all the tumor inside the liver, but the amount of tumor that we have could be completely heterogeneous. That's why in the last version of the BCLC, we consider the liver function, the performance status 0, but also what is the amount of tumor that we have. If you remember, in the past, BCLC-B have only TACE. Now we have some group of patients that could benefit for liver transplantation. Everybody knows that the criteria for liver transplantations are not homogeneous around the world, but we have a specific population that we consider that. Then, in the other side, we have patients who have tumor inside the liver, but is diffuse or is not feasible to do a local regional treatment. In this case, we think about systemic therapy, but the main group of patients still receive the local regional treatment. Then we can discuss if we believe in local regional treatment, TACE or radioembolization. The evidence base today is TACE. So if I have to brief, intermediate HCC is tumor inside the liver without symptoms, and the liver function is not anymore an issue, because if you fit the criteria for liver transplantation, you can consider this option. I believe that now is one of the areas that we really have a lot of things to do.
Emil, how would you like to add anything to this HCC and staging system, particularly from BCLC standpoint?
Well, as usual, I think the oncologists are very more well refined in their definitions. In IR, we try to keep things simple. Obviously, like the patients are going to undergo transplants, depending on the institution's criteria, are easier to handle. And once we have those two other groups, subgroups that you mentioned of BCLC-B, it gets a little bit harder and a heated discussion about how to treat them. So this is good that we're having this discussion to discuss this issue.
Thank you for touching on that. And it's important to address that BCLC, though, is widely used system. Of course, there are other staging modalities, be it TNM. We also have clip staging. So as a community medical oncologist, this can often get complicated. The key here is having these discussions with our radiation oncologist or be it with interventional radiologist. Okay, now that we have this foundation, let's take a little deeper dive in few treatment options for intermediate HCC. Maria, you alluded to this, but Emil, coming back to you. Multiple local regional treatments, be it SBRT, TACE, TARE, Y90, or are we bridging for a transplant? Can you please walk us through some of these available options here?
So the options that we have for local regional options are chemoembolization, which is the old school thing that's been around for like 50 plus years. We have modifications of that, radioembolization, which is radioactive beads, as you well know. That's been around for about 20 plus years. And we have microwave ablation, but in this category, it's a little bit harder to apply. And then you also mentioned the external beam radiation therapy, which again, I'm not a radiation oncologist, but based on the guidelines that I've looked up, it seems like it's mostly confined to cases where we cannot use other curative options. It can be first-line treatment confined for HCC confined to the liver if other therapies are not available, or if a consolidative therapy, if the patients have an incomplete response to liver-directed therapies and salvage therapy as well. That's what I basically gathered.
Can I push you a little more on this? In what scenarios would you use Y90 versus TACE? Today, if you have a patient in front of you, how are you making that decision based on these three modalities?
There has been a lot of evidence coming to the forefront that maybe radioembolization is not only easier for the patients because it's an outpatient procedure for most part, but also because it's been on explant studies and follow-up studies showing much more progression-free survival or tumor necrosis, especially with the personal dosimetry options that we have now. So there's been a trend, not just in my practice, but I think most people's practice, to move away from chemoembolization and move more towards radioembolization, because not only of the side effect profile, you get an advantage there, but also because of the fact that we see better tumor response to it. So we've been moving more and more towards radioembolization for patients for liver-directed therapy.
Can I make a comment here? Because I believe that nowadays we need to understand, and the audience maybe needs also to hear our discussion about that. There's not white and black. Now it's more gray, and there are more and more discussion because the evidence level is different, but also the patient characteristics. So I agree with the previous comment, and I will also add to the audience that we need to consider many factors that are completely beyond the liver function and the tumor burden, and is more related where we are working on and other things, where are the specialists that are in the center, and also the reimbursement. So all of these things now is also part of the discussion for selecting the treatment.
Truly so, because sometimes we are limited with the hospital support, or one only have TACE available, patients don't want to travel. So there are much more complications that are tied in with just administering the treatment. And sometimes how close the tumor is with the vessel and all that sort of stuff ties in as well with the anatomy aspect of it. Now, while we know that this, in general, hepatocellular carcinoma is associated with poor prognosis, as a result, systemic therapies, which have been doing well, at least in metastatic setting, are being put out or brought in earlier stages. We have seen that whether that's standalone or combined with local regional therapies. We've seen that with replace data with regorafenib plus pembrolizumab versus TACE or TARE, Emerald with durvalumab with TACE. Maria, we'll start you off with here. How are you interpreting that, and how are you sort of talking about the data here?
This is also a challenge because today we are talking about intermediate HCC, but when you go to the clinical trials, the population that were included are patient candidates for TACE. That means, for example, the REPLACE trial and also the ABC trial include patients with performance status 0-1, and both of them include patients with all the tumor inside the liver. But for example, REPLACE, Rego plus Pembro, have patients who are beyond the up to 7 criteria. In the ABC trial, we have patients who are beyond the Milan criteria. So the key thing here is the stratification factors, but also consider the primary endpoint. The primary endpoint is also different. In one, the ABC is treatment failure. In the other, in the REPLACE, is the progression-free survival. How do you interpret all of this data? Maybe we could have another session for that, but to be simple, the key thing is identify the patients that were included and also the result that we expect to have results in the next year to know where we are. Maybe we can discuss later on the other data, but generally speaking, I'm happy to say that we expect new data and new information related to treatment failure, for example, and understand better what that means progression-free survival.
Right. I think that's a very good point. I think these therapies, systemic therapies, are showing great promise, especially with combination. And I think one more thing to add here, every time I look at a new study, I'm sure you guys all do this too, because oncology is much more versed in this. It has to apply to our patient population. And as you mentioned, where I'm seeing alcohol, MASH, and Hep C. I'm sure Maria sees a different patient population, and also our listeners in Asia will probably see a different patient population from hepatitis B, etc. So that's always I know it's probably pretty basic for oncologists listening to this, but I'm just good for my radiation, interventional radiology friends.
And just to actually harp on some of that stuff that you were talking about, where TARE is better than TACE itself, and TACE has fallen out of favor, while Emerald itself has been utilizing TACE, we are waiting on Emerald TARE, which is rather more TARE focused. If this was to get approved, are you going to be relying more on TARE aspect of it versus TACE in this case?
My practice has shifted a lot from TACE to TARE in the past 5-10 years. I do still do TACE occasionally, but to be completely frank, it's usually when TARE has not worked or if I think there's a very unique situation. So this is where has been, and I think most of my partners are doing the same thing. But going by guidelines, if we're just doing bridge to transplant, etc., TACE is perfectly viable still in those situations occasionally.
To add to this comment, we also need to remember that at the beginning, radioembolization would focus on patients with more tumor burden. Now, so they are moving more for localized tumor, and it is not data to support that one is better to the other due to the patient population. So again, I believe that we can consider as an alternative option for those who are not candidate for TACE. But if you're in a center that the angioradiologists use this technique, we know that it is safe and have response. So that's why the discussion is beyond what is the priority for the physicians and the patient for sure.
And again, Maria, Emil, you've touched on this. It's not black and white because the real world patient in front of us looks very different than what they usually go in clinical trials. And by the time something is approved, we're looking forward to something else already. One thing in the clinic settings that we often run into is if you're having side effects, is it more so from the TKI that we're giving? Is it more so from the immunotherapy or the local regional therapy that we're getting? Maria, can you touch on this a little more? How do you often dissect as more and more of these therapies are moving early on and now focusing on intermediate HCC?
Yeah, sure. For combination local regional treatment plus immunotherapy or TKIs, we have experience in the clinical trials, and we need to follow the rules for the clinical trials, and then you translate to clinical practice for sure. Systemic therapy depends on the profile of the adverse events. You can induce to think that is more related to one treatment to the other. Frankly speaking, complications after chemoembolization or radioembolization are really, really rare if the patient compensates cirrhosis and so on. So generally speaking, we focus in the profile of adverse events, and depends on that, we discontinue or not. If the patient have a severe adverse events, regardless of the origin, you have to resolve the complication, and then you can decide retrospectively if we're linking for one or the other. But from a clinical point of view, I believe that the most important thing is identify the profile of adverse event that we're talking about.
All this data is convincing, but the real world is, of course, a lot different because there are a lot of factors that are tying in, as we were talking about it earlier, whether that's different practice patterns or different patient profiles, center capabilities, or regional differences, whether one is practicing in Europe versus North America. Maria, let's start off with you here. In real practice, outside of clinical trials, how are you putting all this together and treating patients with intermediate hepatocellular carcinoma?
In Barcelona, we treat according to the guidelines and we treat with TACE. Having said that, if the patient is failure to the TACE or is not candidate for TACE, we could consider radioembolization or systemic therapy. But if you go to the evolution, there are some patients that will also be benefit for SBRT. That means, depends on the characteristics of the patient, we go through different options, depends on the data that we have in terms of evidence. For our group, evidence-based is overall survival, but we know that in clinical practice, some patients are not candidate for that. The only thing that we are not doing, at least up to now, is giving combination therapy, systemic therapy, plus immunoembolization or radioembolization outside the clinical trials, because the data we can discuss later on is not mature enough.
We all are eagerly waiting on overall survival. Emil, you had touched on that as well. This is all exciting, but we eagerly await overall survival before all of us jump on that bandwagon. Emil, coming back to you for local regional control here. Any pearls around sequencing? Maria touched on this, that if someone got TACE, maybe you can still use SBRT. Some of these modalities that you have in hand, be it with IR or radiation colleagues, how are you sequencing that?
So let me just step back for 1 second to address that. I think in the United States, we have been trending towards radioembolization a lot more. And there is actually data already in our journals that's showing the unexplanted livers, you're getting much more complete response, i.e. tumor necrosis, from radioembolization. But of course, those are people who are transplant candidate, and we're discussing patients who have more than one or two diseases. So it's a little bit different because you can give higher doses. Putting that aside, we were talking about, we usually generally start out with radioembolization if we can do it, again, because it's better tolerated for the patients. Let's just say the side effect profile is better, and we've seen that. And you can do TACE more gently, but if you do it, you're going to get less of a response. So I always tell patients who are feeling not so great after a procedure, or at least the treatment is affecting something in your body, right? But if you don't get any side effects, that could also be a bad sign that maybe we didn't treat you as aggressively as we should have. Because there's not just like any one method to do this. I think between my 4 or 5 partners at Georgetown, we have like 5 different ways of doing things, and we've fortunately discussed those. Once we see one therapy doesn't work, for instance, if the patient hasn't gotten a good response, we move to something else. For instance, like you mentioned, external beam radiation therapy, just like their guidelines, if we see that our tumors aren't responding and there's peripheral residual tumor, we might ask our colleagues in radiation therapy to treat them, because frequently there's accessory blood vessels that maybe we can't treat through, like phrenic arteries, internal mammary arteries, and maybe residual tumor in the edge of a tumor. And we ask them for their help to address those issues.
I think this complicated conversation only tends to reiterate that we need to have radiation oncologist, IR, surgeon, pathologist, radiologist, and medical oncologist sitting on the same table when making decisions, especially when intermediate HCC. As we wrap up, Maria, any important studies that are on your radar for intermediate HCC, which you're looking forward to, and importantly, clinical takeaways from today?
Sure. In intermediate HCC, we have to talk about the Emerald-1 trial, the first that improved progression-free survival. But I would like to emphasize the first point that we discussed at the beginning. 57% of these patients were intermediate HCC. The other 16 was BCLC, so advanced stage or early stage.
In your clinical practice, with the presence of positive data based on Emerald-1 and LiPo-1-2, that is combination of local regional therapy with immunotherapy, are you utilizing these practices currently in your practice at all, or rather waiting for the approval itself?
For clinical practice, there are different factors. One is the evidence. We have data, but it's not mature enough. We have chance to think about new options, but we still need to know exactly what is the impact in clinical practice.
If I can make one comment, I think Maria alluded to this. I think it would be really nice if we could recruit more of these patients for trials to get a more definitive answer.
Long-term data and recruitment plays a huge role, especially that's where community oncologist comes in as well to help with the accrual process. But again, involving tertiary care centers for multidisciplinary approach is extremely important. Emil, any final thoughts or key takeaways from you, sir?
I think you summed it up very nicely. Given the fact that we don't have a flowchart for these category of patients, but if you can reach out to, and as I do, to my even colleagues sometimes in more difficult cases, to other institutions, to try to get an answer in a difficult patient, it's very useful. And working as a team, like you mentioned, is extremely important.
Dr. Reig and Dr. Cohen, thank you so much both for your time and insights on this rapidly evolving but complex space of intermediate HCC. For our listeners, let us go over a quick recap. In today's discussion with Drs. Maria, Reig, and Emil Cohen, we focus on treatment strategies for intermediate HCC, from local regional options like TACE, TARE, Y90, SBRT, to systemic approaches and combination strategies.
We also discussed the clinical importance of multimodality approach and the need to personalize treatment based on the patient's specific profile and disease progression. Thanks for joining us. Make sure to check out our other discussions in the HCC series and stay tuned for the final episode on hepatocellular carcinoma. We are the Oncology Brothers.
For more details on all the trials mentioned in this podcast, please visit the Core2Ed website for a complete list with links. If you enjoyed this podcast and want to find out more, then please look for the Oncology Medical Conversation podcast under the account of Core2Ed Medical Education. Also, don't forget to rate this podcast, subscribe to our channel, and share it with your colleagues. Thank you for listening, and see you next time. This podcast is an initiative of Core2Ed and developed by HCC Connect, a group of international experts working in the field of oncology. The views expressed are the personal opinions of the experts, and they do not necessarily represent the views of the experts' organizations or the rest of the HCC Connect group. For expert disclosures on any conflict of interest, please visit the Core2Ed website.